Today's seminar topic is growth and development of maxilla and mandible and its prosthodontic implications. These are the contents of the seminar. A thorough background on craniofacial growth and development is necessary for every dentist. It is also important to distinguish normal variation from the effects of abnormal or pathological process to diagnose and manage the patient successfully. Understanding the growth of the orofacial region is vitally important when planning treatment procedures. Definitions of growth. According to Krogman, it is the increase in size, shape, proportion, and progressive complexity. According to Todd, it is an increase in size. Moyer's, quantitative aspect of biological development per unit time. According to William Prophet, growth is as an increase in size and volume of the cell or number of cells. Definition of development. Todd, development is progress towards maturity. Moyers, development refers to all the naturally occurring unidirectional changes in the life of an individual from its existence as a single cell to its elaboration as a multifunctional unit terminating in death. Thus, it encompasses the normal sequential events between fertilization and death. Theories of growth. These are the various major theories proposed. Remodeling theory. It was given by Brash in 1930. According to him, bone growth occurs oppositionally on the posterior surfaces of maxilla and mandible. Sutures and cartilages have no role. Genetic theory. It was given by Alan Brody in 1941. According to him, growth is controlled by genetic influence and it is pre-planned, but the theory failed to explain the mechanism by which growth occurred. Sutural theory. It was proposed by Seischer in 1952. He stated that sutures are primary sites of growth where intrinsic genetically regulated primary growth of bone takes place. According to him, paired parallel sutures attached to facial skeleton move the nasomaxillary complex downward and forward. The drawbacks: when the sutures were transplanted, there was no tissue growth. Growth occurred in untreated cases of cleft lip and palate. Sutural growth can be restricted by mechanical forces such as clips. Scott's cartilaginous theory. It was given by James Scott in 1961. He stated that cartilaginous sites throughout skull are primary sites of growth and that sutures are secondary. Growth of maxilla is attributed to the nasal septal cartilage. Points in favor of this theory were: in many bones, cartilage is replaced by bone. When epiphysis or nasal septal cartilage is transplanted, growth is seen. Removal of nasal septal cartilage in rabbits demonstrated retarded midfacial development. Functional matrix theory. It was given by Melvin Moss in 1962. This theory states that the origin, form, position, and growth and the maintenance of all skeletal tissues and organs are always secondary, compensatory, and necessary responses to chronological prior events that occur in related non-skeletal tissues or organs or functioning spaces. It consists of two components, the functional matrix and the skeletal unit. Under functional matrix, we have periosseal matrix and the capsular matrix. Periosseal matrix, it comprises of muscles, blood vessels, nerves, glands, etc. It directly acts upon the microskeletal units through transformation to bring about growth. Capsular matrix, it can be neurocranial or orofacial. They indirectly and passively bring about secondary compensatory translation of the macroskeletal units. Coming to skeletal units, we have microskeletal units and macroskeletal units. All these components bring about growth by transformation and translation. Van Limbach's theory. According to him, three major theories were not satisfactory, yet each contain elements of significance that cannot be denied. He suggested the following 5 factors that control growth: intrinsic genetic factors, local epigenetic factors, general epigenetic factors, local environmental factors, and general environmental factors. Factors affecting growth. They can be systemic factors or local factors. Coming to the development of pharyngeal arches, during the 4th week of intrauterine life, the mesoderm of the foregut region becomes segmented to form a series of 6 distinct bilateral mesenchymal swellings called the pharyngeal arches, but the 5th arch is transient and it disappears. As the pharyngeal arches grow, they separate the stomodium from the developing heart. The derivatives of pharyngeal arches are: the first arch is called the mandibular arch. The nerve supplying it is the trigeminal nerve. The skeletal derivatives are malleus, incus, Meckel's cartilage, and the muscles derived are muscles of mastication. Second arch is also called as the hyoid arch. It is supplied by the facial nerve. Skeletal derivatives are stapes, styloid, stylohyoid, and the muscles are muscles of facial expression. The third arch is supplied by the glossopharyngeal nerve, and the greater corner of hyoid is derived from it, and muscles are stylopharyngeus. The fourth arch is supplied by the vagus nerve, and the laryngeal and the pharyngeal muscles are derived from the fourth arch. Development of maxilla. Prenatal development of maxilla. Around the fourth week of intrauterine life, a prominent bulge occurs on the ventral aspect of the developing brain. Below this bulge, a shallow depression is seen, that is the stomodium or the primitive oral cavity. The mesoderm covering the forebrain proliferates and forms a downward projection that overlaps the upper part of the stomodium called the frontonasal process. Mandibular arches on both sides form lateral walls of the stomodium. These are the mandibular processes. Then the mandibular arch gives off a dorsal process called the maxillary process. So at the end of this stage, the primitive oral cavity of the stomodium is covered medially by the frontonasal process, laterally by the maxillary process, and below by the mandibular process. The development of nasal placode divides the frontonasal process into medial nasal process and lateral nasal process. The upper lip is formed by the fusion of maxillary process with the lateral nasal and the medial nasal process. The lower lip is formed by the fusion of mandibular process. Formation of palate. The palate is formed by the fusion of premaxilla, which is derived from the frontonasal process, and palatal shelves by the maxillary process. As the palatal processes grow medially, their growth is prevented by tongue. Thus, initially, palate grows vertically downwards. By the end of 7th week, there is a sudden transformation. The palatal shelves grow to a horizontal position. By 8.5 weeks, the palatal shelves are in close approximation with each other. Ossification occurs at the 8th week of intrauterine life. The mid-palatal suture ossify by 12 to 14 years. Formation of soft palate. As I said, ossification of palate occurs from the 8th week of intrauterine life, but the ossification does not occur in the most posterior part of the palate, giving rise to the region of soft palate. Development of maxillary sinus. The maxillary sinus forms somewhat at the 3rd month of intrauterine life. It develops by the expansion of nasal mucous membrane into the maxillary bone. Later, the sinus enlarges by the resorption of internal wall of maxilla. Postnatal development of maxilla. This basically occurs by 3 mechanisms, that is displacement, growth at sutures, and surface remodeling. Displacement. Maxilla is attached to cranial base by means of sutures. Hence, growth of the cranial base has a direct bearing on the nasomaxillary complex. Primary displacement of maxilla. It is seen in forward direction due to the growth of tuberosity in posterior direction. As a result, the whole maxilla is carried anteriorly. Secondary displacement is a passive displacement of nasomaxillary complex in downward and forward direction as the cranial base grows. Growth at sutures. The maxilla is connected to the cranium and the cranial base by the following sutures: frontonasal, frontomaxillary, zygomaticotemporal, zygomaticomaxillary, and pteriopalatine sutures. These sutures are oblique or more or less parallel to each other. This brings about the downward and forward growth of maxilla. Surface remodeling. In addition to growth occurring at sutures, massive bone remodeling by bone deposition and resorption occurs to bring about increase in size, change in shape of bone, change in functional relationship. Development of mandible. Prenatal development of mandible. Mandible develops from the first arch with the help of Meckel's cartilage, but the Meckel's cartilage by itself does not take part in the formation, but creates a framework for the bone formation. The posterior part of the cartilage forms the incus and malleus and the sphenomandibular ligament, and the rest disappears. The mandibular branch of trigeminal nerve is in close approximation with the middle third of the cartilage, and the nerve divides into inferior alveolar and lingual branches. At the distal end, the nerve divides into incisive and mental branches, and an ossification site occurs on either side where intramembranous ossification of bone starts on the lateral aspect of Meckel's cartilage. At the level of lingula, the bone formation stops and the Meckel's cartilage continues into the middle ear. So the secondary growth cartilages are condylar cartilage, coronoid cartilage, and the symphysial cartilage. Postnatal development of mandible. Ramus. The ramus moves progressively posterior by a combination of deposition and resorption. The deposition occurs on the posterior surface and the resorption occurs on the anterior surface. Body of mandible. Increase in width occurs by bone deposition on the outside. Increase in length occurs due to the drift of the ramus posteriorly. And increase in height occurs due to eruption of teeth. Alveolar process, it grows upward and outwards, adds to the height and the thickness of the mandibular body. It develops in response to the presence of tooth buds. Chin, the ventral protuberance is formed by bone deposition, but the bone prominence is accentuated by resorption that occurs above it, creating a concavity. Condylar cartilage. Growth at condylar cartilage is pressure adapted. Superior surface is depository. Only the cap undergoes endochondral ossification and the rest intramembranous. Coronoid process. The growth of the coronoid process follows the Enlow's enlarging V principle. Deposition occurs on the lingual aspect and resorption occurs on the buccal aspect. Age changes in maxilla. At birth, the transverse and the sagittal dimensions are greater than the vertical. The frontal process is prominent. The maxillary sinus is a mere furrow on the lateral nasal wall. In adults, the vertical diameter is greatest due to the development of alveolar process and the enlargement of sinus. In old age, since teeth are lost, the bone reverts back to the infantile shape. Age changes in mandible. At birth, the mental foramen is present at the lower border of mandible. In adulthood, it is present midway between the upper and lower borders of mandible. And in old age, it is in close approximation with the upper border of mandible. And the angle is 140 at birth, more than 110 degrees during adulthood, and in old age it is more than 140 degrees. Developmental anomalies. Developmental anomalies related to the syndromes. We have Pierre-Robinson syndrome. It consists of a classical triad of micrognathia or retrognathia, glossoptosis, and cleft palate. The primary defect is the arrested mandibular growth, which in turn prevents the normal descent of tongue and fusion of palatal shelves. The clinical features can be micrognathia or retrognathia. Typical bird face appearance is seen. Tongue tends to fall back, hence there is airway obstruction. Cleft palate with or without cleft lip. Coming to Van der Voort syndrome, features are cleft lip or palate and distinctive lower lipids. Hyponasal voice and cleft or bifid uvula are diagnostic clues. Oral manifestations can be maxillary hypodontia, missing maxillary incisors, syngnathaia, narrow hyarched palate, and ankyloglossia. Coming to cleft lip and palate. Etiology, it can be hereditary because of nutrition, vascular supply, alcohol or drugs, or due to infections. There are basically two types, monogenic or polygenic. Polygenic is the most common type. Monogenic is also called as syndromic, and it is associated with various syndromes. Oral manifestations can be there is difficulty in speech, and there can be aesthetic problems, psychological problems. Coming to Parry-Romberg syndrome, it is also called as facial hemiatrophy. It is described by Romberg in 1846. It consists of a slowly progressive atrophy of the soft tissues of essentially half the face, characterized by wasting of the subcutaneous fat, atrophy of skin, cartilage, bone, and muscle. Etiology can be due to cerebral disturbance leading to increased unregulated activity of sympathetic nervous system. Clinical features. Classical coupe de sabre sinus seen, which is a painless cleft near the midline of the face. Unilateral involvement of salivary glands, tongue, larynx, esophagus can also be seen. Oral manifestations, there can be incomplete root formation, delayed eruption, facial asymmetry. Trichocolin syndrome. It is also called as mandibulofacial dysostosis. The clinical features are antimongoloid palpebral fissures with a coloboma of outer portion of lower lids and defective eyelashes. Hypoplasia of bones, especially malar and mandible, malformation of ear, macrostomia, hyarched palate, blind fistulas between angles of ears and angle of mouth, facial clefts, and typical bird face appearances seen. Apert syndrome. It is also called as acrocephalosyndactyly, consisting of a classic triad of craniosynostosis, which is the premature fusion of sutures, hypoplastic middle third of the face, and syndactyly of hands and feet. Clinical features can be brachycephaly, high prominent forehead, hypertelorism, occlusal proptosis. Syndactyly of hands and feet is called as mitten hands and sock feet. Oral manifestations can be mid-face deficiency, drooping of angle of mouth, hypotonic lips, high arched palate, cleft palate, bifid uvula. Coming to the anomalies related to teeth and jaws, we have micrognathia. It can be decrease in size of jaw, either maxilla or mandible, or the abnormal relationship of maxilla and mandible to the skull. True micrognathia can be classified as congenital and acquired. Congenital is of unknown etiology. Acquired can be due to the postnatal disturbance in the development of temporomandibular joint. Clinical features can be severe retrusion of the chin, steep mandibular angle, and deficient chin button. Macrognathia, it is the increase in size of both jaws in relation to the generalized increase of entire skeleton. It is associated with Paget's disease, acromegaly. Factors which influence mandibular prognathism are increased ramal height, increased mandibular body length, increased gonial angle, and decreased maxillary length. Anodontia. Anodontia can be true anodontia or false anodontia. True anodontia can be total or partial. Partial anodontia is called oligodontia or hypodontia. Pseudoanodontia. Pseudoanodontia is something which is associated with multiple unerupted teeth. Ectodermal dysplasia. Etiology. It is caused by the aberrant development of ectodermal derivatives in early embryonic life. Clinical features. Tissues primarily affected are ectodermal derivatives such as skin, hair, nails, eccrine glands, and teeth. There are basically two types of ectodermal dysplasia, hydrotic and hypohydrotic. Hypohydrotic type has dental deformities. The features are hypohidrosis, anomalous dentition, onychodysplasia, and hypotrichosis. Oral manifestations are anodontia or oligodontia, delayed eruption of permanent teeth, high arched palate, conical or peck-shaped teeth. Amelogenesis imperfecta. It is the defect in the structure of teeth. Amelogenesis imperfecta can be of three types: hypoplastic, hypocalcified, and hypomaturative. Fibrous dysplasia. Fibrous dysplasia is the defect where bone is replaced by fibrous tissue in which secondary metaplastic bone formation occurs. Clinical features, there are two types, monostotic and fibrous polyostotic. Clinical features are bone pain, spontaneous fractures, and cutaneous pigmentation called the café-au-lait spots. It is associated with syndromes like McCune-Albright syndrome and Jaffrey's type. Oral manifestations can be pain, swelling, and deformity of the affected jaw. Prosthodontic considerations. Cleft lip and palate. Clefts involving the lip and palate are the most commonly seen congenital disorders. Cleft lip occurs due to the non-fusion of median nasal process. Cleft palate occurs due to the non-fusion of median nasal process with the palatal process. So the incidence of cleft lip is more common in males. Palate is more common in females. Unilateral clefts account to 80% of the cases, bilateral 20%, and syndromic clefts are 50%. Etiology can be hereditary. Environmental factors like womb environment, external environment, nutrition, and drugs. Oral manifestations, there can be congenitally missing teeth, natal or neonatal teeth, enamel hypoplasia, mobile teeth, and protruding premaxilla. So the treatment for cleft lip and palate requires a multidisciplinary team. The treatment procedure is divided into 4 stages. First stage is from birth to 18 months of age. Second stage is from 18 months to fifth year, that is in the primary dentition phase. Third phase is in the 6th to 11th year in the mixed dentition phase. Fourth stage is in the 12th to 18th year in the secondary dentition phase. In stage 1, fabrication of passive obturator is done. Obturator is a prosthetic device that fills the palatal cleft and then provides a false roofing against which the child can suckle. Second, the pre-surgical orthopedics can be carried out. Surgical lip closure and surgical palatal closure is done in stage 1. In stage 2, adjustment of intraoral obturators to accommodate erupting primary teeth to maintain a check on eruption pattern and timing. In stage 3, secondary alveolar bone grafting is done to provide a firm bony support for alar base, elimination of narrow nasolabial, oronasal or nasolabial fistula, stabilization of maxillary segments, and to facilitate teeth eruption. In stage 4, a long course appliance therapy, sometimes in conjunction with orthognathic surgery, has to be carried out. Role of prosthodontists in pre-surgical phase by giving feeding plates to the neonates born with cleft lip and palate to improve their nourishment and growth, providing palatal obturator to the patients prior to surgery. In post-surgical phase, Immediate post-surgical prosthesis, palatal obturator, dental implants, eye, ear, nose, and other facial prostheses, speech aid prosthesis for better speech of cleft lip and palate patients, replacement of teeth for better aesthetics and mastication. Nasoalveolar molding. The primary goal of nasoalveolar molding for both unilateral and bilateral clefts is to reduce the severity of the cleft by modifying the position of the alveolar process and improving the nasal deformity before the primary surgical reconstruction. So the principle behind this is negative sculpting and passive molding. Negative sculpting, serial modifications are made by addition or deletion of material in certain areas to get desired shape of the alveolus and nose. Passive molding, custom-made molding plates of acrylic is used gently to direct the growth of the alveolus to get the desired results later on. So the pre-surgical nasoalveolar molding appliance consists of an intraoral acrylic molding plate and intranasal stents. So this is a picture of a named device for unilateral and bilateral cleft lip and palate. So this is a case treated of unilateral cleft lip and palate treated by nasoalveolar molding technique. This is a case of bilateral cleft lip and palate treated by nasoalveolar molding. Clinical report. A 6-year survival of a mini dental implant retained overdenture in a child with ectodermal dysplasia. Like I said, ectodermal dysplasia is a hereditary disease first described by Thurman and characterized by the abnormal development of tissues of ectodermal origin such as skin, nail, hair, and teeth. Clinical report. A 6-year-old boy presented with the features of hypotrichosis, prominent forehead, flat nose, thick lips, prominent chin and sparse hair or eyelashes, and oral features of edentulous mandible, edentulous maxilla with two first molars with severe alveolar atrophy. The radiograph revealed 2 unerupted maxillary second molars. Cephalometric analysis revealed decreased vertical dimension. The treatment that was planned was construction of a mandibular overdenture supported by 2 mini implants and clasp-retained maxillary removable partial denture. 2 mini implants of 2.9 mm diameter and 13 mm in length implants were inserted without complication. A 4-month follow-up revealed successful osseointegration. A ball attachment mandibular overdenture and a traditional maxillary removable partial denture prosthesis were fabricated. This was the radiographic view of patient at 6-year follow-up. These were the intraoral views of the final dentures. So the multidisciplinary approach, prosthetic treatment, and 6-year follow-up period described have resulted in patient satisfaction in terms of aesthetic appearance and oral function. Case report, multidisciplinary approach for management of a patient with fibrous dysplasia. As I said, fibrous dysplasia is a non-neoplastic hematomatous development of fibroosseous lesion of the bone. Case presentation, a 25-year-old woman with a symptom of painless swelling on the left side of the cheek, which had been enlarging for 3 months. Investigations were radiographic investigations, CT and paranasal sinus view were carried out, which revealed a central bony lesion with diffuse borders and ground glass appearance, which was suggestive of monostotic fibrous dysplasia. By biopsy, tissue showed Chinese letter pattern. Then the treatment that was planned was en bloc resection of the involved site. Then surgical obturator was fabricated. Cast was used for evaluation of occlusal relationship, evaluation of strategic teeth, and for fabrication of surgical obturator. So this is the definitive cast after primary healing. The patient could not afford a definitive prosthesis, hence the patient continued to wear the interim acrylic partial denture. Case report, prosthetic rehabilitation of segmental odontomaxory dysplasia, 7-year follow-up. Segmental odontomaxory dysplasia was first described by Danforth, is a rare unilateral developmental disorder of maxilla. So the clinical features are distinctive unilateral abnormal growth and maturation of the maxillary bone, primarily of the right or left posterior segment and the teeth of the teeth and the covering gingiva resulting in facial asymmetry. Absence of premolars or molars of the affected segment, delayed eruption of adjacent permanent teeth, and hypoplasia of primary molars. So radiographic features, affected bone is dense and sclerotic with coarse, irregular, and often vertically oriented trabeculae. Case report. This was the case of a 47-year-old patient, female patient presented with adequate right intermaxillary relation and left maxillary overgrowth, mainly on the buccal side, extending from the canine region to the tuberosity. The overgrowth resulted in canting of occlusal plane with the upper left second molar occluding with mandibular dentulous ridges in habitual intercuspation. So the treatment plan was overdentures with conus crowns were fabricated. This is the picture where adequate right maxillary interspace for removable partial denture is present, and on the left side there is inadequate space. These are the intraoral views of conus and metal ceramic crowns fabricated to increase the retention of the removable partial denture. These were the maxillary and mandibular dentures that were fabricated. The final restoration in situ. So these are the right and left views of the dentures after 7 years. In case of segmental odontomaxory dysplasia, surgery is the primary treatment, but in this case, diagnostic cast evaluation disclosed that prosthetic design could be applied without surgical corrections. Overdentures with conus crowns supply a validated treatment alternative, even in severe malocclusions, providing increased retention and sufficient aesthetics, and allowing case-sensitive alterations and required modifications. Case report. A comprehensive prosthetic rehabilitation of a case of the orofacial digital syndrome. The orofacial digital syndrome is a genetic anomaly presenting characteristic developmental disorders of face, oral cavity, and digits. Oral manifestations are cleft of upper lip and palate, absence or multiple labial frenum, oligodontia, malalignment, mental retardation, and other CNS deformities, central nervous deformities. Then digital malformations can be clinodactyly, syndactyly, brachydactyly, polydactyly. Facial features can be frontal bossing, hypertelorism, broadened nasal bridge, low set ears. Case report. A 26-year-old girl reported with a complaint of dripping fluids from the nose, difficulty in chewing food, and anesthetic appearance. The medical history revealed that multiple surgical corrections were carried out in the past for correction of lip and palate and nose defects. Dental history revealed that orthodontic treatment was done for 5 years and extraction of 2 maxillary posterior teeth were undertaken. On the examination of digits, the index finger of the left hand had clinodactyly and the left foot digits presented with brachydactyly as well as syndactyly of the 4th and 5th digits. So the right foot presented with clinodactyly. Treatment plan, phase 1. Phase 1 was in phase 1, fabrication of interim obturator was carried out. In phase 2, fabrication of definitive obturator was carried out with the metal framework. So the definitive obturator significantly improved the form, function, aesthetics, and confidence of the patient. So this is the postoperative view after rehabilitation with definitive obturator. In the third phase, fabrication of foot prosthesis was carried out. Impressions of the affected foot were made with modified box technique. And room temperature vulcanizing silicone was used as a prosthetic material. Nylon stockings were placed over the working model on which complete prosthesis was fabricated. Packing of silicone after shade matching was done. Putty indexes of nails were made and custom-made nails were fabricated using autopolymerizing resin. So this is the postoperative view after prosthetic rehabilitation with custom-made foot prosthesis. A knowledge of growth and development is the precious key in diagnosing, treatment planning, and selection of appropriate clinical procedures. Thus, it is a vital key to the mastery of aberrant as well as the normal. These are my references. Thank you.